So we made a very short presentation just to kind of talk about chronic pain, different types of chronic pain and how we can treat that and how we can tailor your pain management individually to you. So this is going to be a really short, informal presentation. If you have any questions during it, please don't hesitate to stop me. I'm going to start though with pop quiz. So the first question is, just raise your hand or shout out the answer. Who here thinks smoking can increase your risk of pain? True. True. True or false? Anyone for false? Yeah, it's true. Next question. Weather affects joint pain. This probably goes hand in hand with my AC friend. True. True? True. True. True is right. Is rest good for back pain? False. False. You guys are not cheating because you're getting all of these right. Next one. Pain is just a regular part of aging. False. False. You guys got 100%. Wonderful. So today we're just going to talk briefly about chronic pain. So what's the difference between acute and chronic pain? So chronic pain is just pain that's exceeding 3 months in duration. It's just hanging around a little bit longer. It's not like acute pain where it might be after an accident, after a surgery, where you kind of have aches and pains and they go away. Chronic pain is more like lasting 3 months in duration. So just some statistics for you about chronic pain in the U.S. About 100 million Americans suffer from chronic pain a year, and with a population of about 327 million in the U.S., that's a third of our population. That's pretty significant. It's actually the #1 reason Americans actually enter the healthcare system. With the most common etiologies that I see in clinic are back pain, neck pain, headaches, migraine, facial pains, and I think a lot of people know that chronic pain doesn't just come with physically hurting. There's a big mental component to it too. And a lot of patients that have chronic pain also can have psychiatric issues as well, which is expected, and those need to be addressed too. So this is going to talk a little bit about our model for pain management at ACMC. And so typically when you come into the hospital and you have new pain, acute pain, or chronic pain, you go and you see your primary care doctor. Your primary care doctor then can evaluate you and see how long has the pain been around for, how severe is it, and then if they feel the need to send you to more specialized care, that's where you come to see me or one of the 2 other providers at ACMC. And so you go through your primary care physician and then you see someone like me who is board certified and trained for pain management. And I'm not the only one that will be treating you. We have a multidisciplinary approach to pain management, meaning you'll have a pain doctor, you'll likely see a physical therapist. I recommend a lot of my patients to see other doctors like rheumatologists if you have arthritis, neurologists if you have some kind of neuropathy symptoms. So it's really getting you the best care from a team-based approach of physicians, nurses, therapists, all together working. So why is it important for hospitals to focus on pain management? This little chart just kind of shows you with some of the other big problems in the U.S. like cancer, heart disease, and diabetes, chronic pain is up to 7 times more prevalent than some of these other big diseases. So that's why it's really important to us to focus on treating chronic pain. When you don't give chronic pain a good team-based approach, you have a lot of problems that can come from that. Patients not being treated appropriately for their pain, they get frustrated, they leave the healthcare system, they're going to the emergency room all the time, primary care and family medicine doctors not knowing how to treat these types of issues. So all these problems can kind of result from that. And so that's why this slide kind of shows you how patients, when that happens, they kind of get clustered around to where you're hopping from doctor to doctor and no one's really addressing your issues how they need to be addressed. So this is just kind of showing how patients can kind of see all kinds of doctors before seeing the one that can help with their pain the most. I like that slide too, just to kind of go back, because again, it encompasses a lot of people that you should be seeing to help with your pain. So not just a pain doctor, but a physical therapist, a neurologist, a rheumatologist, a lot of different people to help you with your problems so we can have the most success at treating your pain. So at ACMC, we have 3 providers. Other way.
Oh wait, sorry guys.
So we have our main location, which is at ACMC. We're on the second floor in the pain clinic. I have 2 clinic days, Mondays and Fridays every week, and then I do procedures on Thursdays. And there's another physician there, Dr. Hill, and we have a nurse practitioner too, Cynthia. So we have a team there to help with whatever you might need. So for balanced pain management care, a lot of people think pain management is just about taking medicine, but really to best treat your pain, it's through a multimodal approach. So typically when you come in to see me, I evaluate your pain, see how long it's been going around for, see where it could be coming from. I'll look at your x-rays and imaging, do a little physical exam, and then I kind of tailor a plan based on just for you. And that plan will usually include physical therapy, occupational therapy, maybe some medication management, as well as some interventions, which I'll talk about a little bit later, based upon where you're actually hurting. So a tenet of good pain management is having responsible care, and that means making sure you're a part of your own pain management. So whenever you come into the clinic, we have you sign something called a service agreement, and that's just making sure we're both accountable to making sure your pain gets better in a responsible and safe fashion. We have a big team there, so communication is really important. I have a wonderful nurse manager, Rebecca. We have great nursing staff, and we work really closely with other neurologists, rheumatologists, orthopedic surgeons, and as well as your primary care doctors to make sure we're taking care of you from a holistic approach. So some of the most common diagnoses that I see in the clinic, which you guys might have some of these going on, are obviously neck pain, mid-back pain, lower back pain, muscle aches, nerve injuries. These could be related to just some kind of trauma or maybe a work-related accident, migraines, facial pains. Basically, any part of your body can hurt, so we see it all. So the interventional services I was talking about before, so in addition to doing physical therapy and some medication management, we also offer interventions. Some of you guys might have had these interventions before. We do joint injections, like injections in shoulders and knees. We also do injections in the spine. This can be for back pain, pain radiating down your legs, pain in your feet. And so I'm going to talk a little bit more about each of these types of injections to give you an idea of the different types that we have. So an epidural injection, some of the ladies here might be familiar with that. These typically are what women get when they go into labor, but we also use them in pain management to help for back pain and pain down the legs. There's specialized epidural injections called transforaminal injections and nerve root injections. Let's say you only have pain going down one side of your body. We can do specialized injections just for that. There's also, so this is just showing us how we do an epidural injection. So this is your spine. These are the little yellow guys are your backbones. So basically from your neck all the way down to your tailbone, you have 24 building blocks or backbones. And in between those backbones, you have little squishy discs. That's these guys. They're kind of like jelly donuts. They act like shock absorbers for your spine. And then behind all of that, you have a lot of ligaments to help support your spine and all of your movements. When we do these epidural injections, we have you come into the operating room and lie on your stomach, and it takes about 5 minutes. We clean you off with a little bit of soap and water, go in with a little needle about the size of a bobby pin, and we enter through your back, in between these little backbones to a space called the epidural space, and that's outside of your spinal cord. And that's where we deposit some medicine. It's usually a numbing medication and a steroid medication. And the purpose of that is to try and help calm down some of that nerve irritation and inflammation that's happening in your back as well as in your butt and down your legs, hips. Just like you can get arthritis in your big joints, you can get arthritis in those little joints too. And when you have back pain secondary to arthritis of your FACET joints, I can go in and I can inject those joints too and see if we can get you some relief that way as well. These are some less common procedures that I do, but you might be familiar with. These are sympathetic blocks or spinal cord stimulation. Sympathetic blocks, which are the first 3 blocks, are usually when you have chronic pain that might be secondary to, for example, you've had abdominal surgery, you have chronic abdominal pain, or you had a work-related injury or some kind of traumatic injury, and you have really bad out-of-proportion pain in a limb. in an arm or a leg, and there's something called complex regional pain syndrome, which a lot of these other procedures are for. I also do something called spinal cord stimulation. This is basically if you have really bad back pain and you're not responding to regular injections, or you might have a history of back surgery and you still have pain. This is a newer modality we use now to even help those patients, and it's through electrical stimulation, kind of like a TENS unit for your spine. So that's about it, just a quick little rehash of what we do and how we can hopefully help you guys if you do have pain. And so if you guys have any questions. Sure, I mean, it all depends upon, you know, where his back surgeries were, where do I think his pain might be coming from, what type of pain is it? Is it pain from inflammation? Is it arthritic pain? Is it pain from nerve damage? And then kind of taking it from there and seeing, you know, what would be the best plan for this person. We would start conservatively, maybe with some medications, see if that helps. If that doesn't help, I still do different types of injections even after back surgery, like that transforaminal injection. That's something that you can do after back surgery, which is very selective in where you can place it. That can help a lot. And then spinal cord stimulation is another option where you can actually put in, they're like little fishing lines into that epidural space we talked about, and it connects to a little remote control where it then stimulates the spinal cord to help with pain relief. So actually having back surgery is the main indication for having spinal cord stimulation. So typically we would just like for our patients to have like a primary care provider, just so they're good at helping coordinate, like I said, physical therapy, knee, any other doctors you might be seeing. But if you just call, I think we have some brochures up here with my number on it, so you can just call and make an appointment. You know, we definitely recommend a holistic approach. So, you know, interventions aren't right for everyone, medications aren't right for everyone, but I'll tell you, every single one of my patients gets counseled on exercise and diet. The healing starts from inside out, for sure. Typically, you know, I advocate physical therapy for everyone, even though it hurts in the beginning. It's going to hurt in the beginning. I usually tell all my patients that when you're strengthening surrounding the bone, tendons, muscle, ligaments, tissues, in the long run, that's going to help with your pain and your strength. Medication-wise, there's a lot of medications that are used for arthritis, whether that's, you know, anti-inflammatory medications, which you're probably the most familiar with. These are like your ibuprofens, Advil, Celebrex, you know, medications like that. When those stop being as effective, you can use other agents, like they're called disease-modifying agents. These are like things rheumatologists typically prescribe, like methotrexate, Plaquenil, hydroxychloroquine, things like that. And then they also biologic agents. These are agents that you can typically get infusions for, like Remicade, Enbrel, things like that. Personally, I do a lot of injections for patients with arthritis. So when you have knee pain or shoulder pain, joint hand pain, I can typically inject those joints. What I inject in those joints is kind of dependent upon what you've already had and how bad your arthritis is. If you're bone on bone, sometimes when you do cortisone, which a lot of patients do, it doesn't last as long. So you have other options you can inject in joints too, like synthetic collagen, to try and mimic what naturally happens in our joints. And so with steroids, you know, you want to limit how much steroids you get every single year. I'll do about 3 or 4 injections a year for patients safely. Even if you have diabetes and things like that, I just tell my diabetic patients to kind of stay on top of their sugars around injection time. But typically, as long as you do medications in low quantities and low frequencies, you don't really have to worry about side effects from them. But basically, there's a lot of different options for arthritis. I mean, it can be pretty progressive, pretty debilitating, but we have a couple good options to help keep you active. And aquatherapy. I recommend aquatherapy to a lot of patients that have arthritis or have joint replacements, because you're buoyant, you're floating in the water, and that's a lot easier on all your joints. So a lot of my patients really enjoy that too. Good excuse to get a swimming pool.
Yeah.
So typically when patients have arthritis in really fine joints, like in their hands or in their feet, I also, besides starting with some kind of oral medication, I use a lot of topical medications too, because these joints are very small, and you have to be very particular when you inject them, because there's not a lot of extra space going on here. So I use a lot of patches and compound creams that are specially formulated just for you. So if you're complaining to me about a lot of feels like it's cramping and my joints get really red and inflamed, then I'll give you a cream that has an anti-inflammatory and a muscle relaxer in it, as well as something for pain. When it comes to injections for hands, I usually refer those patients over to like a hand specialist, because they are really cognizant of the anatomy of the hand and where those injections should go. But I think starting conservative with creams, medications, therapy is usually where I start, and then interventions are usually kind of the most invasive of our options.